Okay, so I felt like maybe we didn't give everyone a chance to say what they wanted to say about this topic. So we're going to finish up here before we do a Kahoot. But I want to remind you that the first midterm is this weekend. Yeah, and Tone's excited. And so you should get access starting at noon on Friday, and you must be finished before midnight Sunday. And once you start, you can start whenever you want, but once you start, you have to finish the allotted time, 90 minutes, I think. There'll be 100 multiple choice questions, and they come in slots of 10, and you have to finish answering one batch of 10 before you go on to the next. Hopefully you took the pretest, which counts for nothing, but gave you an idea of what the format is like. So you should be familiar with that. And I've never done the test this way in this class before. I tried it out in a different class in neural development last time, and I kind of liked it. What it gains for me is I don't have to take up 3 class periods with a midterm, right? And so you could say, oh, so you get to yak more, and we're forced to listen to you, which is true. But also, I think it makes more room for us to have group projects and things like that once in a while. So far, everyone's feeling comfortable with the group projects, with the idea of it. Hopefully, it feels like a nice break from me droning on. Right. Okay. Any questions about the midterm? They'll all be like this. I think the exception is, available noon Friday, finish it before the weekend's over. The exception is the one before the October break, and I think I made that available at 6 in the morning, because maybe some of you really don't want that hanging over the start of your break. So, questions? Okay, you'll think of some. Joke. Who has a joke? Volunteers, please. No? Ah, excellent. Okay. All right. Nice and loud, slow.
Why is there no pregnant Barbie?
Why are there no pregnant Barbies?
Because Ken came in another box.
Okay. I realize I've heard it before. And that version was Ken came in his box. So, or his boxers, I don't know. Yeah. Okay. And this is skirting the fact that none of these dolls are anatomically correct. So when we're done with this chapter, the next one, the one after the midterm, you'll understand what Ken's missing. By the way, so this midterm will cover the introduction, the Appendix A, Chapter 1 and Chapter 2. It will not cover Chapter 3 on male anatomy, right? So female circumcision. Anyone want to speak in favor of it? Or even if you're not in favor of it, can anyone want to offer any arguments to support the idea? Be very brave. Yeah. Hold on.
I guess one argument people could make in favor of it is that it's like cultural, and in like some forms are less damaging than others. They could like argue that, oh well, there's cultural reasons, so we have to do it, and like everyone's done it, and this is how, like, this is just what we do here, kind of deal. I'm not for it though.
Yeah, I think that's an argument for. And of course, the fact that anyone would even bring that sort of argument to bear, I hope you realize that that's a phenomena that began in the mid-20th century. Until that time, it never occurred to anyone in the United States that any traditions other than the ones favored by the founders of the United States and their progeny deserved any respect at all, right? And so there's this weird thing that many of the immigrants who came to the United States, by that time, say, many of them never actually learned their native language because their parents made a choice of not speaking in the old tongue because you were supposed to change. And so you're the beneficiaries of this different attitude that thinks, the way things were always done is worth considering. Also, considering other cultures as their traditions being unimportant, you can see how that's totally tied up with colonialism, right? I mean, that's just part and parcel of that idea, right? The British are going to go to Africa and explain to people how they ought to do things. The missionaries are going to go to Hawaii and tell them who gets to have sex and how. I mean, it's, and that idea, of course, is still rather prevalent, and you could even say it's prevalent in our society today. Yeah, you were going to say.
Yeah. So there's this whole argument for male circumcisions that it lowers UTI and STI rates. Hypothetically, you could say the same thing for females.
Well,
Not saying that that's true, but I'm tying it back to that.
Okay, you've jumped ahead with you, but anyone else want to offer any arguments for female circumcision? And so how many of you then, so I take it that everyone, you're unanimous, you are opposed to female circumcision. How many of you are opposed to male circumcision? How many of you are opposed to female circumcision, but not opposed to male circumcision? Uh-oh, come on. You got to raise your hand, one or the other. You're opposed to male circumcision, or you're not? Who's not opposed to male circumcision? Plenty folks, right? Anyone want to tell me what's different? We'll talk about male circumcision when we talk about chapter 3. And by the way, in the United States, it's quite prevalent, and not just among cultural groups that have practiced it for years, right? The Semitic people, Jews and Muslims, right? It's most males in most parts of the country are circumcised a few days after birth. So who wants to explain how in your mind they're different? That the rationale for male circumcision is different from that for female circumcision? Well, okay. You were suggesting, and I'm sorry, I forgot your name. Sarah, you were suggesting that there might be some health benefits to male circumcision. You're saying minimal ones.
Sure, the textbook says that it's not significant enough of a difference.
Well, I think what it says is that it's not significant, by which it means statistically significant. That was an idea that was out there at one time, but the data just hasn't held it up. Now there is, of course, there are ways to avoid sexually transmitted infections, right? We'll talk about one later today that far and away the most effective thing you can do, the Gardasil vaccine. But it's not clear that male circumcision has any health benefits. And so any of you who, I mean, for you, it all hinges on, is there a health benefit? If there's a health benefit, then you think it's okay. And if there's no health benefit, are you going to change your mind? Anyone? Okay. Yeah. Go on. You're saying if it turns out there's absolutely no health benefits, what's your stand going to be?
Female circumcision, it is trying to, there is more of a tone of preventing women from having sex, and whereas male circumcision doesn't have that same connotation.
Okay, so for you, it's the intent that matters. And of course, some cases of female circumcision, they leave the clitoris alone. They do a little bit of surgery down there, maybe just snipping off a bit of the clitoral hood. That's the prepuce, right? That's directly analogous to male circumcision. If that was the kind of female circumcision, is there anyone here that would then be okay with it for a traditional reason? I know that's not what you were saying. Yeah, Amber.
I'm wondering, your question is, what's the difference between male and female circumcision? Why would we feel strongly about preventing one or like not allowing one and then leaving the other one alone? And to that, I would say, female circumcision, the potential for damage is a lot higher than for the male circumcision. It's more invasive. There's more they can do with that. Some people, as you said, they just shut the whole thing closed, and so I would say they are different. And that's how I justify that I feel more strongly about maybe saying female circumcision is not allowed, but male circumcision is.
Totally defensible.
I think there's, however, like in terms of like damage, I think sometimes we also have to think about the psychological damage that can occur when, for example, if a male were to undergo circumcision and then they were to grow up and they didn't like they feel like, oh, like that's something I wish didn't happen to me. It can cause a lot of psychological effects, same similar to how like a woman who undergoes like female circumcision might look at her genitalia and might feel like, oh my god, like something is wrong with me almost.
So I think you feel like it would leave more of a psychological scar in women than men because it might impair sexual function. But there are some men who claim that the lack of a foreskin impairs their sexual function. Oh, that was your point, yeah, Ian.
So I'm actually in favor of it being the same thing, considering it the same thing.
And therefore, you're opposed to both.
Yes, I'm opposed to both. Well, the thing is I think some of the stuff that people aren't mentioning is that with male circumcision, especially as young as men are circumcised, there also is the propensity for their penises to be cut off accidentally, just because I mean it's so small. And then also the popularization of circumcision in America is mostly due to they saw it as an anti-masturbatory device, and I don't know if it was created by, but I know it was popularized by the Kellogg brothers.
They have many things to be blamed for in trying to curb sexuality, but not that one. And I think you're right. I think male circumcision was intended. I think it became popular outside traditional circles, actually, for two reasons. One is that it might reduce masturbation. No, I'll give three. Second is it's a lot easier to clean. Having a foreskin means you got to go to a little more trouble to clean underneath there, right? I mean, that's undeniable. But also, how hard is it to wash yourself, right? It's not every once in a while there'll be a foreskin that is attached a little bit too much so that the glands can't be pushed back, and a little snip of the frenulum, the middle part, we'll more about that later, and that takes care of that. The third reason was that it made physicians a lot of money. What's the original reason for circumcision in Jewish traditions and Jewish and Muslim traditions? Yeah.
I believe it was God's covenant with Abraham.
Yep. So that's one version. That was covenant with Abraham. And so that way Abraham and all his male offspring would be identifiable because, God has a really hard time telling them all apart otherwise, right? Also, when you're going someplace and killing lots of people to take over their land, it's good to know who's who. So I'll bet in Sunday school you were never told that King David, before he became king, he was a rebel leader out there, and he collected foreskins as trophies, knowing that he'd killed Philistines, right? Non-Jews. Had lots of them. He snipped off lots of foreskins from dead foes. Okay, so it's not easy to know that wasn't the reason. How do I know you're my tribe and not some other tribe? Okay, question? We'll talk about males and male circumcision shortly. So, time for a Kahoot, don't you think? Come on. Okay, so here we have a midline sagittal view of the female reproductive tract. And there's lots of stuff here, and much of it you've seen before. we haven't talked before about the internal structure. So the easiest way to keep track of these various names and structures is to think about the pathway that either sperm has to get to an egg or egg has to get to the outside world. And so the vagina, we've started with already, because you can see the external opening of that externally. And it is, of course, between the urethra and the anus. Inside the vagina, we haven't looked inside before, there are these rough corrugations that are known as rugae or folds, vaginal folds. The interior of the vagina is highly vascular, highly sensitive, and it's the interior of the vagina that will provide lubrication. The blood vessels there are specialized to exude and to filter out of plasma a slippery, sticky stuff to make intromission, penis or dildo into vagina, easier. So that's where the lubrication comes from. And if we go inside, the vagina interfaces with the uterus, and the opening of the uterus, this kind of cap-shaped, we're not seeing it as a cap here because we're looking at cross-section, is known as the cervix. And the opening from the vagina enters the cervix, and this opening is eventually going to allow sperm to get to an egg and egg to get to the outside world. Okay? More about that later when we have a different view. The other thing to be keeping track of here is to know where the bladder is. And the main point is the bladder is kind of settled between the uterus and the pubic bone, which is not going to move. And so the uterus, when the woman's not pregnant, is relatively small in size, but of course, eventually is going to hold, a 10-pound baby in there. And at that point, there's a lot of pressure on the bladder because it's being squeezed between a hard place and a baby, basically. And ask your moms about how often they had to pee when they were pregnant with you. She'll explain. There is here a thing that you hardly ever hear discussed, a so-called periurethral gland. We'll talk about that some more later. And what else do I know? Here we're seeing the clitoris, just this portion, and there's that ligament I told you about that anchors the clitoris to the bone, to the pubic bone, there at the midline where the pubic symphysis is. And we're seeing here in cross-section those pelvic floor muscles that we talked about before, bulbocavernosus, istiocavernosus, and those are, here we're seeing them from the side, and they are connecting to the pubis and various other bones and to other structures. And then here are the muscles that make the external anal sphincter that encircle the anus and when tightened, close the opening of the anus. And I don't have it listed here, do I? Well, we'll see what this structure is in a moment. And again, a very technical term is that region between the vagina and the anus is sometimes known as the perineum. And so you'll hear doctors talk about perineal muscles, or there's a perineal nerve that's important, et cetera. Yeah.
During intercourse or arousal,
Mhm.
the vagina kind of gets deeper. What parts here mechanically need for that?
Yeah. So during sexual arousal, there are times when the vagina can lengthen in shape, and so it's somewhat elastic, and that's to do with the structure of the vagina itself. It's not that the cervix has to get out of the way or something, right? And even when there isn't arousal, the vagina is highly flexible, right? It can be stretched quite a bit. Doesn't mean it's stretched without pain, but it can be stretched quite a bit. Again, eventually a baby's head's going to pass through there, right? Which would normally be impossible. Cervix, oh yeah, yeah. So the opening is the anus, and that first bit of the large intestine is the rectum. So the rectum is the space, and the anus is the opening. And you go further up, you see colon and stuff like that that we don't care about. Seeing from a frontal view, you get a better idea of where eggs come from. So in a frontal view, then on either side of the uterus, there are these tubes that extend one to the left, one to the right, that are known as the oviducts because eggs, ova, pass through them. They're also sometimes called the fallopian tubes, and there's sort of a movement away from naming stuff, keeping anatomical terms after particular individuals, not just because sometimes those individuals weren't so nice, but also because I think the idea is that the other names might be easier to remember because what's an oviduct? It's a duct that ova pass through, right? But I'm old, so you'll hear me say fallopian tubes once in a while, and I apologize, but you'll be okay. So these tubes, the oviducts, reach out and note that there are ligaments that are holding them in place, connective tissues, and they each then sort of open up, sort of like a trumpet horn. They open up, and anchored outside both the left and the right is the ovary itself. And here we're seeing a lot of fatty tissue cut away so we can see the ovary. This is more of what it looks like from the outside, where again, it's encased in a lot of fatty tissue around it. And a lot of that is there for protection. And from the outside, it looks like a kind of a whitish lump of grapes or something that are been squeezed together. This view also lets you see that the oviducts, that they don't really encircle the ovary entirely. They have these little fingers that are known as fimbria that more or less encircle, they don't encircle, but they go around the perimeter of the ovary. And the other thing here is you can refer to this opening of the cervix as the os. You might see that once in a while. Here, this view is to point out to you that the cervix isn't just the portion of the portion that can be seen inside the vagina, but actually extends a bit further. And while the vagina is very stretchable, the cervix is less so. And yet, one of the things that's going to have to happen for a baby to find its way out of here is the cervix is going to have to soften up a lot. And for 39 weeks or so before the baby is ready to come out, the cervix serves as a barrier to keep the baby in. And it's a tough thing. What's going to happen before birth is hormones and other things are going to start softening the cervix. And the baby getting squeezed out that opening is going to make it go thinner and thinner, about which more later. Within the uterus, there are 3 layers, and they're easy to remember. The layer on the inside is the endometrium, and it is surrounded by a layer of muscle, and that's the myometrium. So the uterus, once there's a baby in there, as it gets bigger and bigger, the baby is surrounded by a tunnel of muscle. And what's going to squeeze the baby out is those muscles are going to contract, and they are extremely strong. And so they're going to contract and push the baby against the cervix and eventually out. So you got to have muscles in your uterus, right? Or you're not going to give birth to anybody. So that's the myometrium. And on the outside, it's the layer of tissue that's around things. It's the peri, like in perimeter, the perimetrium. The endometrium is that portion of the vagina that in the course of a menstrual cycle gets thicker and thicker and then is eventually shed in some bloody mixture of cells, etc. I'll tell you now that most mammalian species do not menstruate. That is, their uterus goes through thickening and thinning every ovulatory cycle, but they don't shed the inner lining, they just absorb it. But some species, humans and several primate species, among them also dogs is the other species you might have been. Some species not only, some species menstruate as part of their ovulatory cycle. Questions about that? Trying to be. Oh, the other thing I want to tell you about this is that, of course, here's the pathway by which sperm and egg can meet, right? The sperm enters through the vagina. The sperm have to fight their way inside the cervix, up the cervix, and eventually have to reach the oviduct. The egg, in the meantime, has been released from the ovary once every 28 days or so, and it is traveling down the oviduct. The walls of the oviduct are filled with little hairs, hair-like structures called cilia, that are constantly beating away from the ovary and into the vagina in that direction. So we'll talk later about what happens when the ovary releases an egg. A little part of the egg swells up and kind of explodes, and in doing so, an egg is sent out, and it will then land in the opening of the oviduct, and the cilia are to push the egg upstream.
Are they beating when the woman is ovulating, or are they always beating?
They're beating all the time, because who knows when an egg might get released, right? It sometimes happens that an egg is released and it doesn't get in the oviduct, but ends up outside the oviduct. And normally that's not a problem, but if a sperm manages to find it there, then if it fertilizes it, there may be an embryo that's developing outside the uterus, and that's a life-threatening position, so-called ectopic pregnancy, where there's a embryo trying to grow someplace that's doesn't belong, and where it might eventually rupture a blood vessel or something, internal bleeding, and the person dies. So be glad for cilia. There's an important thing about timing for human reproduction, which is as the egg is making its way down to perhaps meet a sperm, if a pregnancy, successful pregnancy is to happen, that meeting, that fertilization has to take place inside the oviduct. If, as is very often the case, if the egg gets past the oviduct before sperm are gathered and can get their way up there, if the sperm fertilize the egg inside the uterus itself, that embryo is not going to survive, because it turns out for it to embed in the walls of the uterus, which is what a pregnancy requires, the embryo has to have gone through several divisions and must be mature enough to get to latch on the endometrium and make a placenta and stuff like that and survive.
Since it's dangerous for pregnancy, like for fertilization to happen outside of the oviduct.
Yep.
And also, kind of, you think people would evolve so that fertilization is more likely to happen, because
Yes.
why does the oviduct seem lazy about grabbing that?
Yeah, well, one answer is most of the time it works, right? And that ectopic pregnancies are relatively rare. And also remember that until modern times, again, on the plains of Africa where we all came from, most of the time, every woman who had reached reproductive age was either pregnant or lactating or both. And in general, when you're lactating in those sorts of societies where nobody has enough food, lactation halts ovulation. So if you're nursing a kid for 3 or 4 years, no pregnancies result. And then as soon as ovulation resumes, they tended to be pregnant again. In that lifestyle, every woman might have a total of 10 ovulations in her lifetime before the whole thing stops. So ectopic pregnancy, there really wasn't anything for natural selection to act against. It's just not a big enough risk that any mutation arose to stop it. On the other hand, here we are, all are, and I had thousands of mothers and grandmothers, et cetera, and it worked out for all of them. Good. Great questions. Love it. Okay. Oh, but again, this means that if a couple have sex after the egg has left the oviduct, there'll still be a fertilization, still be an embryo, still be a conceptus, and in some jurisdictions, there will be a human being exists at that point, but it's doomed. It will be lost in the next menstrual flow, and odds are nobody will even know it was ever there. And that's quite common in cycling women who are sexually active. Okay. More about the ovary. It's about 3 centimeters long, so about an inch. It's somewhat spherical. It's, as I said, sort of a lumpy mass covered by tough connective tissue on the very exterior. And inside, it consists of lots of follicles, little circles of tissue that are, again, encircled by tougher tissue and therefore make little spheres. And so when I say it looks like a bunch of grapes, it's kind of structured like a bunch of grapes too, right? All kind of packed together. And each follicle has some inner cells known as granulosa cells. That just means they're small and grain-like. But they're also surrounded by a layer of outer cells called thecal cells that are important for support of the granulosa cells. And dead in the center is an ovum. Before it's been released, it's an oocyte. The oocyte will eventually get released from the ovary, and that process is ovulation. So all mammals have ovulatory cycles. Some are spontaneous, like in humans. Some are induced by sexual relations, like cats and rabbits. They all have ovulatory cycles, but not all mammals have menstrual cycles. A menstrual cycle is an ovulatory cycle that's accompanied by sloughing off of the endometrium of the vagina. In general, human females are born with about 1 million oocytes, all of which, I'll remind you, were created through the process of meiosis, where initially diploid cells eventually produce cells that were haploid and therefore could possibly make an embryo. Almost all of them die, all those millions of oocytes. And by the time puberty comes, there's about 200 left. And most of those are never released. They never let go. I guess, oh, pardon me, 200,000. I was going to say, that can't be right. Yeah, so thousands. So there's been, tenfold lost at least. And I told you the fimbria are supposed to catch the ovum. And the ovum, by the way, it'll consist of an oocyte in the middle, but often when it's released from the ovary, there might be some other cells that are attached to it, sort of hangers on, but that's okay. And what happens is after the follicle has swollen, ruptured, and released the egg, then the follicle, it doesn't just die, but it collapses and starts making hormones. Actually, it's been making hormones all along. So the follicles have been releasing one kind of ovarian hormone, estrogen. And after ovulation, when the follicles collapse, they start making another ovarian hormone, progesterone, about which more later. So the follicles are very important. And both those hormones, those ovarian hormones, those are steroid hormones, about which more later. Questions then about any of this? Yes, Nick. What's the evolutionary benefit of menstruation? It's not clear. Because, I mean, but there is another parallel that has occurred to me. And so the other thing, if a woman is pregnant and the pregnancy is lost, right? That happens sometimes. Things go wrong and the baby isn't developing properly and it's shed in a miscarriage. What's interesting about rats and mice, for example, and lots of other mammals, if a rat dam a female animal that is intended to breed is a dam. Anyway, in a rat dam, if they're really stressed, they sometimes don't, abort the fetuses. They absorb them, and they can absorb them very late in the process. And you can see how that's maybe, just take it apart and reuse those resources. You can see that's kind of advantageous. Of course, humans tend to only have one baby at a time. And so maybe it's just a difference in resorption ability in our species, although why that would happen, I don't know. The other clear function of menses is a signal. It lets the woman know something's happening. It lets other individuals know something happening. And in most mammals, other animals can smell those animals, other animals with menses, other animals can smell that.
What are the specific steroid hormones that are released by the follicles?
The specific steroid hormones are estrogens and progesterones. We'll talk about what they do and what their names are. I'll just say that it's a sequential business. The estrogen is preparing the uterus for implantation. And if a pregnancy, and the progesterone is maintaining the uterus to let the embryo fetus have a chance. Great questions. More about the fallopian tubes. I guess I already told you about the cilia. They're spelled out for you. And we can talk about the parts of the oviduct. There's a narrow part that's really close to the uterus, and that's called the isthmus. And just like in geography, what an isthmus is, a thin part of land. That's how you can remember that's the part of the oviduct that's closest to the uterus. There's the wider part next to the ovary, that's the ampulla. That's sort of like the cup-like portion. And then there's the funnel-like infundibula and infundibulum with, pardon me, let's show it. And then there's the infundibulum, this portion, with the fibria. And here's a cross-section of an ovary where you can see these follicles. Here's a follicle, there's a follicle, there, etc. And as a follicle ripens, which is being driven by hormones controlled by the brain, as a follicle ripens, it swells and gets bigger and bigger. And what happens then is the oocyte and attendant cells within that get to be isolated from the walls of the follicle, and eventually it will swell so much that it will burst. And it's always the surface, outside surface that bursts. And in that, the ovum is literally, physically pushed out, pointed towards the fimbria, right? And the infundibulum and parts of the oviduct. And here's another view, closer up view. Here's the ovum, here's the cavity. This follicle is getting bigger and bigger. So far, the ovum hasn't detached from the walls of the interior of the follicle, but as it gets bigger and swells more, that will happen. Questions? We will talk about this process from several different angles, and we'll even end up going over it several times. What's left of an ovary when a woman's out of eggs? For the most part, the ovary will still have loads of eggs when the woman enters menopause. And so they stop ovulating, and so they're just there. If you start out with 200,000, and if you're not in the plains of Africa, but you're here with us these days, and you have 12 ovulatory cycles a day, or pardon me, a year, and you live to be 100, you haven't made a dent in the 200,000. Yeah.
People often are like, oh, I have however many eggs left. But
So in general, the short supply isn't the number of eggs. It is how long ovulatory cycles, how long the brain will continue to push for ovulatory cycles. Okay. And in general, women reach menopause with plenty of the eggs left. Now, what sometimes happens, as we'll see in IVF, is the woman might be treated with drugs. We'll explain what they are in a moment, to have lots of eggs ovulate at the same time. So the surgeon can go in and harvest many ripe follicles and therefore many ripe eggs for fertilization outside the uterus, et cetera. And in those cases, I've never heard of anyone suggesting that there's not enough. Or if there isn't enough, it's not because they ran out. Great question. Okay. Now the uterus, also known as the womb. So the uterus is where the embryo is going to develop. Once it reaches the point, the embryo has developed to the point where we can distinguish individual structures. We don't call it an embryo anymore, we call it a fetus. Technically, it's still an embryo, but the fetus is a more specific name because it refers to a developing individual that has structures. Sorry. So the cervix then lies between the vagina and the uterus, and it is considered part of the uterus. It's the opening of the uterus, but it's a very distinct structure, so it has its own name. The external opening there is known as the os, and it runs through the cervix. It's the cervical canal. One way in which the cervix is different from the rest of the uterus and quite different from the vagina is it secretes a mucus that is very conducive to sperm transport. And so that's an important function. Inside the uterus, we just talk about the cavity inside it. We just give it the same anatomical name for any cavity inside a structure. It's a lumen. We'll run into other lumens and other structures, but that's all it means, opening. And I've already told you it has 3 layers: the internal endometrium, which is spongy, highly vascular tissue that will be great for an embryo to implant in and start making a placenta. And if that doesn't happen, will be shed at the end of the ovulatory cycle to start over again. The muscular myometrium that contracts during birth, and the technical term for birth is parturition. That's the birth process. And then there's that thin peritoneal layer that separates the uterus from the abdominal cavity. It is exceedingly tough. Lots of connective tissue, crisscrossed every which way, highly connected together. And that needs to be the case because once there's a baby in there and the myometrium is contracting, if the exterior of the uterus isn't super tough, then that contraction could cause a rupture there, right? You see that? And looking at the structure of the perimetrium, where is it? Oh, well, also a peritoneal layer. You know those white shipping envelopes that are made of stuff where you look, everything's sort of crisscrossed, et cetera? Sorry, the first time I saw one of those, first thing I thought of was the exterior of the uterus, right? You too, probably, right? So it's lots of long chain molecules crisscrossed every which way that end up making a really tough sheet. And you've noticed you can cut that kind of envelope, but you really can't push through it. It's just too tough. Okay, and of course, in natural parturition, there's nothing to cut that tissue. So there is this myth that during Victorian times, women who had enough money and were having psychological problems, maybe caused by the fact, they had no job and nothing really they had to do because, did I mention they had money, and they weren't expected to or encouraged to do anything actually useful. Supposedly, they would go to doctors who would help them feel better by giving them a massage under the covers, of course. And the idea is that doctor massaged the clitoris until they had a paroxysm. Yeah. And they left feeling better for some reason, the women did. It was all science. And this is almost certainly a myth. Nobody knows how it got started, but there's no evidence that, in fact, this practice ever happened in real life. Although there's a pretty funny movie that's based on the idea, I don't remember the name of it, of these Victorian doctors having their rich, and making a lot of money by having their rich female patients come to their office, disrobe under a sheet, and then for them to massage them. Yeah. Pardon? Yes. And it was supposedly a treatment for hysteria, which was a catch-all phrase for any time a woman had a psychological problem. It was, she was thought to have a problem with her uterus, that was caused by her reproductive organs.
Yes, one of the ideas was like because the woman was not pregnant or like not fulfilling her biological like requirements, it was said that her uterus would be filled up with because it was a wandering uterus, which that's why they went crazy.
Sometimes hysteria was caused by a wandering uterus. Yes.
Yeah.
Yep.
So it
Even
was
unanchored.
so it was filled by like a toxic liquid, and that's the best way to like excrete it.
Yep. And Sigmund Freud, he got his start studying hysteria, women with strange symptoms that couldn't be explained neurologically. And who else had their hand up? It was Maya, right?
I feel like this, I learned that this did happen because the vibrator thing was a real medical device that was used. So
yeah, you can read that it happened, but latest I've seen from historians that are trying to look back at that, it's a will-o'-the-wisp. It's an idea that's firmly ensconced. I can't say it never happened, but I can tell you, I think consensus now among historians is that it didn't happen. But it's a great story. What is true is this business of dismissing women's symptoms as hysteria, right? That has certainly been true at least as far back as Aristotle, right? This idea that women, if their reproductive bits weren't working properly, it caused them to be crazy, right? Where they would, so if they're having a hard time feeling like their only role in life is to copulate and have babies and feed them, if they balked at that, clearly they were crazy, right? Who wouldn't want to do it? Because the natural order of things is, of course, that's what they're supposed to do. And we'll see lots of misogyny like that here. The very term hysteria is referring to the uterus, right? So if the uterus is surgically removed, that's a hysterectomy. So it's named, this disorder, hysteria, is named after the idea there's something wrong with your uterus, not your head, certainly not society, it's your uterus that's at fault. And so we got to work on that. And often, a treatment suggested was to get pregnant. Question? Okay, we're going to have a deep dive now into the hormones that are driving ovulation. And if you haven't gone through it before, you're going to feel a little pressed. Don't, because we're going to go over this at least 3 times. Okay? So try to get the idea, and eventually the details will come. So the decision about whether to ovulate, every decision that is made about what your body's going to do, including whether you're going to reproduce, it is always and everywhere controlled by the brain. The whole point of having a brain is to gather information about the outside world, including other individuals, and to make decisions about when is and isn't a good time to reproduce. So the brain's in charge of everything. Just remember that. This is why you want to be a neuroscientist, right? Because the brain's in charge. Whatever the process is, the brain has a major role in it. So there's a portion of the brain, part of the diencephalon, the bottom part. The diencephalon, I'll remind you, it's named because it has two parts: the thalamus, which you learned about when you learned about sensory processing, and beneath that is the hypothalamus, which is named for the fact that it's beneath the thalamus. The hypothalamus is relatively small portion of the brain, but it is packed full of function, and it is any physiological process that you know about or that anyone knows about, the hypothalamus plays a role in it. You can sort of think of it as the end of a funnel of information from the cortex, from sensory regions. It's all funneling down into the hypothalamus to make decisions about your life: breathing, respiration, diet, everything, right? So the hypothalamus is sort of a clearinghouse of information. And the hypothalamus releases hormones that are known as gonadotropin releasing hormones. Gonadotropin, these are some gonadotropins called follicle stimulating hormone and luteinizing hormone. They're called gonadotropins because they go to the gonads. Men and women both have gonadotropins, the same gonadotropins, and in both cases, the job of these gonadotropins is to act on the gonad. Now, what can be confusing is the gonadotropins are produced by the pituitary. And in the early 20th century, as people realized how profound the changes were in physiology, if you lesioned the pituitary, it became known as the master gland. Because whatever hormone you were looking at, if you lesion the pituitary, they were going to get screwed up. But what was discovered in the second half of the 20th century is that all the hormones being released by the pituitary are in fact being controlled by the brain. Because remember, I told you, the brain's in charge of everything. And specifically, it's the hypothalamus that controls the release of gonadotropins from the pituitary. And the hypothalamus does that by releasing its hormones, which are totally different than the gonadotropins. And so these hormones we call gonadotropin releasing hormone. We're going to pretend there's only one, and there is one principal one, and that'll work for us. And we'll abbreviate it GnRH, and it's called a releasing hormone because the hypothalamus releases it and controls what? Gonadotropins in the pituitary. Okay? So I'm sorry that it's that complicated, but that's how it is. And this particular arrangement, this is universal across the vertebrates. All the vertebrate species have a hypothalamus, and they all have a pituitary, and it's always the hypothalamus that controls the hormones from the pituitary. So the brain decides, let's ovulate. It's time to ovulate. We're old enough, we're good enough, we've got enough to eat. By golly, let's ovulate. And then it will trigger ovulation by releasing gonadotropin releasing hormone into the stalk of the pituitary. And I'll give you more detail about that in a moment. The GnRH travels that very short distance in circulation to get to the anterior pituitary, specifically. And there it acts on cells in the pituitary that produce and release gonadotropins. And if you push me, I'll tell you the cells are called, unimaginably enough, gonadotropes. But who cares? And the pituitary will release two different gonadotropins. And they are named after their action in ovaries, but they also are crucial for male reproduction. But we're going to talk about females now. So the first gonadotropin that is released in the course of an ovulatory cycle is called follicle stimulating hormone, FSH. And its job is to stimulate the follicles to make them ripen and further develop and eventually release an egg. So in the human ovulatory cycle, there'll be a week or 10 days where lots of follicle stimulating hormone is being released by the pituitary and is preparing the ovary for ovulation. And then the pituitary starts switching from producing lots of follicle stimulating hormone to making luteinizing hormone. Terrible name, I didn't pick it. And the luteinizing hormone is going to trigger the last bit of maturation and cause ovulation itself. So there's got to be some FSH prepping the ovary, and then there's got to be some LH causing ovulation itself. It's easy to know why follicle stimulating hormone is called that. It stimulates the follicle. Why is luteinizing hormone called that? Well, lutein is the Latin root for yellow, because the follicle, once it releases the egg and collapses, I told you that already, right? When it collapses, it turns literally yellow, bright yellow. You can't miss it. So if, for example, you sacrifice a female rat and open her up and look at the ovaries, you'll know if she's released a lot of eggs lately, because there'll be 5 or 6 big yellow bodies that you can see with your naked eye through the outside of the ovary. So it's called luteinizing hormone because it causes the follicles to turn yellow. We call that body, you'll see later, the yellow body, only we use Latin, we call it the corpora lutea. And it'll be the corpora lutea that will, let's see, the follicle is releasing estrogens, about which more later. Yeah, here we are. The follicles are releasing estrogens, which act on lots of parts of the body to prepare for pregnancy, including the endometrium of the uterus. And the luteinizing hormone, when it causes a yellow body to appear, the corpus luteum, or the several corpora lutea, secrete a different hormone. They secrete progestins. And progesterones are called that because they are progestational. They promote pregnancy. They keep the uterus in a pregnant state, so the embryo and fetus can develop until it's ready, until it's possible to survive. So and the most common estrogen are the estradiols, and the most common progestin are progesterone, and they act on the uterus, breast, lots of other organs to prepare for reproduction. So, to get back to Sophia's question, if you want to understand why a woman might be having a hard time getting pregnant, one of the things you might measure are the gonadotropins. What are FSH and LH levels like, right? Are there enough to stimulate the follicle to release? Another thing you might want to know is, what are the ovarian hormones like, estrogen and progesterone? And are they cycling normally? And if you want to harvest a bunch of eggs for in vitro fertilization, where you want to go in once and try to harvest a lot more than one egg at a time, you will give the woman drugs that are gonadotropin mimics. So basically, they are synthetic versions of FSH and LH, and they will cause the follicle not to produce just 1 or perhaps 2 ripe eggs, but they'll start ripening maybe a dozen. And then the surgeon goes in and plucks them all out before they have a chance to be released. So see how much you understand about medicine now? Kamika, yeah. Yes. That's a great question, and we're not ready for you. But it's a perfect segue. Did I pay you to ask me that question? No. Because the other important part of this chart is shown here, where we're talking about how the same hormones that go into circulation and prepare the body for pregnancy, they also, of course, reach the brain. The whole point of hormones, they go into the bloodstream and they reach everywhere that there's blood circulation. And that is crucial for controlling ovulation because these hormones go and report to the hypothalamus how much estrogen and progesterone the ovaries are producing. If there's not very much estrogen and the brain thought it sent enough to get estrogen going, it might then release more GnRH, which would boost FSH and LH levels in order to push the system a bit more until it reaches a point where there's enough estrogen. If the first bolus of the gonadotropins worked and the follicles are releasing estrogen, once the brain knows that, it stops releasing GnRH. So the signal that began in the brain, let's ovulate, release GnRH, make gonadotropins, once it works and the brain is making hormones, then that cuts off the supply. So this is known as negative feedback because the process triggered feeds back to the system and inhibits it from happening anymore. And it's a good thing because otherwise, what if you made too much estrogen, right? That could be bad for you in all sorts of ways. And the negative feedback is acting both in the hypothalamus and the pituitary. So not only is less GnRH being released by the hypothalamus, but the pituitary is less sensitive to the GnRH that is produced. And so all of this functions to reduce gonadotropin level. Now, what's wrong with this diagram that brings up your question is it suggests that the inhibition, the negative feedback, is only carried by estrogen. But in fact, progesterones also work as excellent. They also provide negative feedback. And so when we talk about birth control pills, we'll talk about how the first ones consisted of estrogen. These days, they often consist of a combination, et cetera. So now you understand how birth control pills work. Because if I give you estrogen before you've had a chance to make your own, I fool your hypothalamus. Oh, no need to release GnRH. There's plenty of estrogen already. And that means your pituitary releases no gonadotropins. Oh, nothing to do here. We got plenty of estrogen already. And therefore, no gonadotropins, FSH and LH levels will stay low, no ovulation, you can't get pregnant. I mean, when things work. And we'll talk more about birth control pills later. Notice that ovaries also produce androgens like testosterone, which you might not be expecting. But in fact, there's plenty of reason to think that a little bit of testosterone from the ovaries are important for sexual function. And if you've been told that there's some hormones that are male hormones and some that are female hormones, you've been given bunkum. It's not true. There's no such hormone. There is no hormone that occurs only in one sex. The difference between male gonads, testes, and female gonads, ovaries, is that ovaries produce lots of estrogen, progesterone, and a little testosterone, and testes produce lots of testosterone and not so much estrogen and progesterone. Okay. Questions about that? Good. Androgens, yeah. There are several syndromes that can cause women to have somewhat masculinizing features, and almost always androgens like testosterone, maybe not testosterone itself, are responsible. And we'll talk about why that might happen. Okay. So now I'm going to take you through a series of graphs to keep track of these various hormones in the body. And it's going to go fast, but don't panic because we're going to do it again. Plenty of time. Okay, here we're looking at the course of an ovulatory cycle. by convention, we start thinking about an ovulatory cycle at the commencement of menses. The ovulatory cycle begins on the first day of menstrual flow. And so for 3 or 4 days, there'll be menstrual flow. And then there's the part of the phase that is known as pre-ovulatory, where the ovary is getting prepped for ovulation, pre-ovulatory. And during that time, both FSH and LH levels are rising. And when the peak of LH happens, that triggers ovulation per se. This very complicated pattern of hormone results is totally typical of hormonal secretion. Every hormone that your body secretes is always released in a complicated pattern across the course of a day. And this is one reason why no pharmaceutical substitutes can ever quite totally mimic the biological effects of hormones, because you have to make do with a sort of a crude treatment instead of a subtle one. And then once ovulation takes place, the rest of the ovulatory cycle is the post-ovulatory phase. And if at this point, no pregnancy results, in humans and lots of other spontaneous ovulators, the process starts over again. In humans, it takes about 28 days. Question. On average, lots of variation. Why 28 days? Anyone think of any natural phenomena that varies on a 28-day cycle? Yeah. The moon. Oh, yeah. It takes about 28 days for the moon to make a full rotation around the Earth. Go through, new moon, half moon, full moon, blah, blah, et cetera. Why would that matter for ovulation? If you know, come talk to me. I'll make you second author, and we'll both become famous, because nobody knows the answer. No one has any idea why. And it may just be a coincidence. But if so, it's an awfully fishy coincidence. Yeah. Wait, don't tell anyone else, because we've got to publish first. But no, I'm kidding. What? You think it's because women are paying attention to the moon? Okay, I can't think of any way to disprove this. And what you really mean is that as we evolved, women were paying attention to the moon, and that somehow that affected genes that control ovulatory cycle. Okay, you have another Keegan? No, what's your name? Keegan. Yeah. Okay. Well, I can't think of a way to disprove that hypothesis either. I just want to show you one more graph. And so here's the consequence of gonadotropins: is the follicle is releasing lots of estradiol, and then it stops. And now the corpus luteum starts releasing progesterone, and the progesterone will keep the endometrium of the uterus ready for implantation only up to a point, because the corpus luteum is a timing device. It will only release progesterone for so long, and then it stops. And once the progesterone goes away, the endometrium is shed, and it's time to start over. What can maintain the endometrium, even as the corpus luteum starts producing less progesterone? A fetus. And so what happens now is either a pregnancy results, in which case progesterone levels stay high and the ovulatory cycle is interrupted, or no pregnancy results, the corpus luteum releases less progesterone, it goes down, the endometrium is lost, and the whole system starts all over again. Okay, when we get back, we'll talk about what that means here. Okay, and my aim is to finish chapter 2 on Thursday.